Great. Okay, well, welcome everyone, and thank you for joining us. My name is Amy Harris. I'm the manager of the Patient-Centered Primary Care Home Program. And this is our our webinar series to help practices and their partners prepare for the 2025 recognition criteria, which is going into effect in January. So this is one of many webinars in our series that we started in the spring, and we're continuing through the end of this year and possibly into the beginning of 2025 as well. So today we're going to be talking about PCPCH Standard 4E, which is hospital setting transitions. And so we have two of my colleagues in the PCPCH program that will be presenting on that measure today. And so I'm going to go ahead and turn it over to them to tell you more about this measure. And of course, we'll have lots of time for questions and answers at the end of the presentation.
Awesome. Thanks, Amy. Good afternoon, everyone. My name is Susan Almanci, and I'm a Program Operations and Policy Analyst with the Patient-Centered Primary Care Home Program.
And hello, I'm Amber Anderson. I am an improvement specialist with the program.
Thank you for joining us for our webinar on PCPCH Standard 4E Hospital Setting Transitions. First, just a few webinar logistics and Zoom etiquette reminders. The webinar will be recorded and uploaded to the PCPCH program website. If you're having any technical difficulties, please private message Amy Harris for help. If you feel comfortable, please have your camera on and put your name and organization info up. Any questions or comments you have can be put in the chat and we'll answer them during the question session. And for the agenda, I'm going to start by providing a brief overview of the 2025 PCPCH recognition criteria. Next, we'll deep dive into the PCPCH Standard 4E hospital setting transitions. Next, we'll share additional PCPCH resources and upcoming learning collaboratives. And finally, we'll have some time for your questions. The Patient-Centered Primary Care Home Program was established in 2009 by the Oregon Legislature as part of the state's broader health system transformation strategy to improve access to care, reduce costs for patients, and improve population health. The standards are developed in partnership with an advisory committee and have been revised 5 times since 2009. The 2025 PCPCH standards were developed to support OHA's strategic goal of eliminating health inequities by 2030. The standards specifically help primary care practices build their capacity and processes to address inequities in their patient population. All practices applying or reapplying for PCPCH recognition after January 1st, 2025 must meet these new standards. For more information, I would encourage you to watch the recording of the 2025 PCPCH Standards Overview webinar, which is on our website. Okay, so here is an overview of PCPCH Standard 4E. This standard is called Specialized Care Setting Transitions under the 2020 model, but it will be called Hospital Setting Transitions under the 2025 model. PCPCH Standard 4E is in core attribute 4, continuity, which from the patient's perspective means be our partner over time in caring for us. The intent of Standard 4E is that care coordination and communication during transitions is an important aspect of patient safety, especially between inpatient and outpatient care settings. PCPCHs should take responsibility for facilitating appropriate transitions of care by developing relationships with their patients' usual providers of hospital care. The 4E standard is progressive, which means practices can select the measure level that best describes their practice with a maximum of 10 points. This standard has increased from 0 points to 10 points due to the addition of the new optional measure of 4E2. 4E is a must-pass standard, which means practices can attest to both measures in the standard, but at a minimum must meet measure 4E0 to qualify for PCPCH recognition. Measure 4E0 states a PCPCH has a documented process for transitions of care with its usual hospital providers or directly provides routine hospital care. And again, this is a must-pass measure. This is not a new measure to the standard. However, we've broadened the measure language and documentation requirements to allow for more than just a written agreement with your usual hospital providers. Measure 4E2 requires that PCPCH has a process for following up with its patients post-discharge from the hospital and emergency room departments and is worth 10 points. 4E2 is a new measure to the standard. After meeting with community members, our advisory council, and our health equity consultant, Ignatius Bao, it was decided that adding a measure focused on the way practices are being notified, doing outreach, and following up with patients after a hospital visit was critical in providing practices with the framework to develop relationships with their patients and the hospital or emergency departments that they are transitioning from.
Thanks, Susan. Now we're going to take a deeper dive into each individual measure. We're going to start with measure 4E0. A practice is meeting measure 4E0 if it has a documented process for transitions of care with its usual hospital providers. The documented process can take form of a written agreement with its usual hospital providers or a written protocol, policy, or workflow describing transitions of care with these hospital providers. The following should be included in the documented process. First, the practice's process for requesting hospital admissions for patients, expectations for hospital communication with the practice at the time of a patient's hospital admission, the practice's process for sharing patients' medical records at the time of the hospital admission, and how the hospital communicates with the patient's discharge summary with the practice at the time of the hospital discharge. Practices are no longer required to have a formal written hospital agreement, so long as they have a documented process as described in these specifications. A practice can also meet this measure by directly providing routine hospital care to its patients while they're in the hospital. Here are two examples of what this measure could look like implemented in your practice. A practice has a written policy and workflow for managing transitions of care with its local hospital. The practice routinely reviews the policy and workflow to ensure that its processes remain relevant for its patient's population and makes changes if needed. Second example, a practice is part of a system which includes a hospital, and there is a written protocol and workflow for transitions of care with that hospital. As you're completing your PCPCH application, we strongly recommend you gather and collect all documentation that would be needed for a site visit. At a site visit, you would be required to show this documentation to the PCPCH program to demonstrate you are meeting the measure. For measure 4E0, here are some examples of what you would need, either one of the following: a copy of the written agreement with the practice's usual hospital providers or the practice's policy, procedure, or workflow for managing transitions of care that has all the necessary requirements found in the specifications, or for those providers that routinely provide hospital services to their patients, we would need a formal workflow or protocol around hospital coverage that is provided. Now we're going to talk about 4E2. A practice is meeting 4E2 if it has a documented policy, procedure, or workflow for following up with its patients after they are discharged from the hospital or emergency department, which should include the following: how the practice is notified when a patient is discharged from the hospital or emergency department, the practice's outreach methods to the patient to coordinate and schedule follow-up appointments with their primary care provider, pharmacist, behavioral health consultant, or other care provider, the practice's performance expectations for scheduling after discharge follow-up appointments. And although it's not required for this measure, ideally the post-discharge follow-up would be performed in a way that is culturally and linguistically appropriate and considers the patient's health literacy needs. Here are a couple examples of what this measure could look like implemented in your practice. As per their documented policy, a practice devotes medical assistant staff time to conducting hospital follow-up calls with their patients and families within 3 days of a hospital discharge, to schedule for a follow-up with the patient's primary care provider, and assesses needs such as helping to coordinate with other medical providers or procedures. A pediatric practice receives a notification that 3 of its patients were seen in the ED the night before. The patient's care teams are notified as per the practice's discharge workflow policy. They review the discharge notes in the electronic health system, or by requesting them from the hospital if needed, and determine the need for a call to the family and or to schedule up a follow-up within the week. Again, as you are completing your PCPCH application, we strongly recommend you gather and collect all documentation that would be needed for a site visit. For Measure 4E2, here are some examples of what you would need. A copy of the practice's policy, procedure, or workflow that for following up on hospital or emergency department utilization by their patients that contain all of the requirements listed in the specifications, and evidence demonstrating follow-up with patients or families after discharge from the hospital or emergency department. And that could look like chart notes, phone notes, or other documented outreach.
Okay, so the PCPCH program is hosting this webinar series to assist practices and other community partners in understanding the standards. Webinars are scheduled every other Friday through December. You can find a complete list of topics and registration information on our website. The next 3 webinars are listed on this slide. The measures are going to be a little out of order, but I hope you'll join us. If not, webinars will be recorded and posted on our website if you can't make it. This final slide is additional resources that you may find helpful. The first is our PCPCH program website. The second is the 2025 TA guide with detailed information about how to implement every measure and the documentation requirements. Next is a link to our TA resources page. And finally, the community engagement report and evaluation. Lastly, you are always welcome to reach out to the PCPCH program with any questions through our program email. And now we will open it up to questions as this concludes our webinar on Standard 4E. Thank you so much for joining us. And now we'll just open it up to questions.
I had to unmute myself there. You think I would have gotten the hang of this after so many years, but nope. So thanks so much, Susan and Amber, for presenting on that, on that standard. That was a pretty quick presentation because this measure is pretty straightforward. As we mentioned, or as Susan mentioned at the top of the webinar, we just had one new measure in this standard, and the other one, the must-pass, just had some minor revisions. So we wanted to just open it up now and see if folks have any questions about either the must-pass measure and the changes that we've made to that, or the new measure and kind of what we're looking for in those policy and procedure documents. Before you answer your questions, I don't see any in the chat. I will just add one of the things that we did when we looked at revising the PCPCH standards for this next iteration in 2025 is we really, really focused on not only improving the model overall to advance equity, but also looked at ways that we could reduce the administrative burden for practices. And we've done that in a variety of ways, mostly through documentation, but also through changing some of our requirements on workflows for practices, things like that, just to more align with what's actually happening in practices and also to alleviate some of that workflow. So that is the primary driver, or was the primary driver of the change to the must-pass. As you probably all know, we have required a formal agreement with your usual hospital providers, the hospitals where your patients usually go. We no longer are requiring that formal written document or agreement form. You certainly can have it. That's really would be great. Ideally, we would love to see that, but we're also allowing the documentation to be a process or a workflow that would be an internal document to your practice that really demonstrates what that relationship is. So it could be either one of those things. And again, that really was a direct response to helping reduce the administrative burden. That is a must-pass measure. We know a lot of practices, or we have had over the years, practices who find that getting that actual agreement form to be a bit challenging sometimes, depending on who has to sign it at the hospital. So we're really hopeful that this change to this documentation is welcomed by practices, and to just know that we hear you, and we're trying to make the process a bit easier in ways that we can, but also stay true to the intention of the measures and the standards as well. So I'll just add that one little bit. So it looks like we have one question so far in the chat. So let's see, I'll read it out loud. Thank you for your first question, for opening it up. Is it acceptable to not have a follow-up clinic visit with the patient post-ED visit? May not be required. Okay, hold on. Is it acceptable to not have a follow-up clinic visit with the patient after the ED visit? May not be required. I don't think that we're necessarily requiring a follow-up visit with the practice. I would defer to, I see Amber nodding. So I don't know, Amber, if you, and Meg nodding, I see folks nodding. Okay, go ahead.
It's more of your outreach method. You know, not everyone's going to need a follow-up, and we don't expect you to do that either. So it's about how you're following up with them, how you're determining if they're going to need a follow-up or not. And then, you know, showing us on those patients where it is necessary to have that appointment, that you are scheduling that follow-up, but not a requirement for every single ED visit.
Yeah, that's a great question. And thanks for asking that. And thanks for clarifying, Amber. Other questions folks have? You can either put them in the chat, or you can raise your hand, or just unmute yourself and blurt it out. We're okay with that too.
Hi, this is Danny. I had a question in regards to I think it was the 4.E0, where we can submit documents with the agreement or agreements that we have with hospitals, is my understanding. Does it have to be all the hospitals, or at least one, to show that we have an agreement with the hospital, since we have clinics in both, or in multiple cities also too, right? So like the hospital that the patients might go to are different. So I just wasn't sure if you needed just one or all of them.
So depending on your location, it's going to be whichever is that location's usual hospital provider. So it might need to be multiples. So, you know, if you have a clinic, let's say in Tualatin, Oregon, where there's Meridian Park Hospital, that's probably going to be your usual hospital provider. If you're up in Portland or Gresham area, Legacy Mount Hood might be your usual hospital provider. So, you know, if you had one Legacy policy that would or agreement that had both locations, like this is my usual agreement for my Gresham patients at this location at Mount Hood, and here's my agreement for my Meridian Park, or it could be two separate systems. If you have multiple locations in the Portland area, and Providence Portland is your usual hospital provider for multiple locations, then we would just need one if that is your usual hospital provider for multiple locations, if that makes sense.
It does. Thank you.
And also, I'll add too, we haven't actually talked about this as a team, but I think I could see this being a possible scenario. You may have a combination of both a written hospital agreement and that internal protocol. So for example, if you have two different hospital systems that you're working with, or that your patients usually go to two different hospital systems, you may have like a formal written agreement with one, and then maybe you have a protocol document that reflects the relationship or the process that you have with the other. And that would be okay as well. I'm just double checking to see folks nodding to saying yes. I mean, we haven't talked about that scenario as a team because we haven't done site visits on this yet, but I could see that happening potentially. So just know that it doesn't have to be all one or the other. So. Okay, let's go to the chat. Okay, so Stan makes a comment here. Although it may not be a requirement for a PCPCH, it may be if you're contracted with Med Advantage plans. So yeah, that's a good point. We appreciate that. Sometimes that fall, and I assume you're talking about the follow-up visit post ED. And you're right. I mean, depending on what insurance carrier your particular patient has, that could be a requirement for that particular patient. You're exactly right. And then let's see. So Jacqueline says, do you mean like a workflow for this? I assume you're talking about the document that we mentioned. Or do you want to unmute, Jacqueline?
Yeah, sorry, for the hospital
okay.
agreement. Okay.
Yep. Yes, correct. Yes, correct. Other questions folks have? I got excited there. I thought we had another question. Okay, well, I don't see anything else in the chat, nor do I hear anybody unmuting. So I think we gave it a long enough. Oh, actually, we did have a question come in. Where can I see the social determinants of health %? So it looks like that question came from Danielle. So that is not a part of this standard. Are you asking about another standard in the measure or in the model, or did you want to unmute yourself? Olson Peds made such improvements in this area. I feel Olson Peds made such improvements in this area. Okay, sorry, might not worry. Where can I see the social determinants of health percentages? So Danielle, I'm not exactly sure what you're talking about in your question, and it sounds like your mic's not working. If you're asking for specific information about how maybe Olson Pediatrics is doing on some of your social determinants of health screening metrics, that might be what you're asking. Maybe we can talk about that offline. You can. Okay, perfect. So why don't if you don't mind reaching out to the PCPCH inbox, or you can reach out to me directly. I think we've communicated before via email, and we can try to figure out what that information is for you and definitely talk with you about that. We'd be happy to do that. Yep. Yeah, good. Thank you for bringing that up. All right, well, everyone, again, I'll just remind you that as I just told Danielle about reaching out to the PCPCH program inbox, you are welcome to reach out to us at any time about either this standard or any other standards or measures in the model. Even if we haven't covered them yet in a webinar, even if we're planning to cover them, let us know, ask us a question. Who knows, it might change the way that we present the measure when we do the webinar. Your questions often lead to us saying, that's a great question, we should talk about that. So if you have something that's on your mind, definitely reach out to us at any time. Rachel, who you see on our screen here, is the one who is the person behind the email inbox. And she either answers your question directly or she reaches out to one of us on the team if she doesn't know the answer, which isn't very often. Rachel knows a lot. So thank you all for joining us. And we'll be sending out a survey after this, as well as a link to the recording if anybody would like to share it with your colleagues. And I hope that you have a great weekend. So thank you very much for joining us. We'll see you next time. Bye.
Thank you.